Good afternoon, or for our West Coast colleagues, good morning. Welcome everyone to the At a Crossroads, the Syndemic of Syphilis, Substance Use, and Child Welfare During Pregnancy webinar. I'm Tim Harrison, Principal Deputy Director for the HHS Office of Infectious Disease and HIV/AIDS Policy. And this webinar was developed in coordination with the National Syphilis and Congenital Syphilis Syndemic Task Force. In the chat, you will find more information about the task force. Before we begin, I want to invite Rebecca Lazeration to cover basic housekeeping for the webinar today. Rebecca?
Thank you. During today's webinar, if you have any questions, please feel free to unmute yourself if you are a panelist. Otherwise, please put all of your questions in the question and answer, and we will get to those as we are able. For our panelists, remember to mute yourself unless you are speaking. When you are speaking, feel free to turn on your video. And as always, if there are any problems and technical questions, please feel free to reach out to me directly. Thank you.
Great. Thank you, Rebecca. Today's webinar will highlight the interaction between substance use, syphilis, and policy during pregnancy, and showcase best practices and successful policy solutions that will help us address the needs of the people we serve. Next slide. There we go. Today we are joined by 5 expert speakers. Together they will share their experiences providing reproductive, sexual health, and substance use care, as well as their thoughts about ways to provide more holistic service delivery. We will also hear how policy has a direct role in health outcomes. Before closing out the webinar, our speakers will respond to a few questions raised by you. The information shared by the speakers today do not necessarily reflect the position of HHS or the Federal Syphilis Task Force. In addition, the topics discussed may be sensitive. I encourage all in attendance to engage as openly as possible with the shared goal of improving the health and lives of people, their children, and their families. Next slide, please. Before I introduce our first speaker, I want to take a few minutes to ensure everyone has a baseline understanding of syndemics and the state of syphilis and congenital syphilis across the United States. A syndemic is the population-level clustering of health and social conditions and the syndemic social and structural factors like the lack of quality health care or violence can make people more likely to be exposed to and experience disease or health conditions. Having one health condition can also make people biologically, behaviorally more likely to acquire another illness or experience worse outcomes. For this webinar, the syndemic is defined as the interaction of substance use, infectious disease, and structural policies that affect the delivery and access of prevention, treatment, and care for pregnant people and their families. Next slide, please. In 2022, the United States reported the greatest number of syphilis cases since 1950. Some of the most alarming concerns center around the continued increases among congenital syphilis, which can lead to preterm birth, stillbirth, and infant death. Next slide. There are significant disparities among the percentages of babies born and reported cases of congenital syphilis cases by race and ethnicity. The greatest disparities were observed among Black or African American mothers and American Indian or Alaska Native mothers. Next slide. Finally, when looking at cases of congenital syphilis, the most common misprevention opportunity was inadequate treatment followed by no timely test. And we know from a recent study by the CDC that individuals with congenital syphilis pregnancy outcomes had nearly twice the prevalence of substance use compared to those without. with approximately half experiencing late or no prenatal care. The importance of substance use in driving congenital syphilis cannot be understated. That is why we convened this webinar today. Now I want to introduce our first speaker, Dr. Mishka Turplan. Mishka, please take over.
Hi, and thank you so much for inviting me to this really important convening. I am Mishka Turplan. I'm an obstetrician gynecologist. I'm also boarded in addiction medicine, and my real interests have been along the intersections of reproductive and behavioral health, with an increased emphasis recently in like how that intersection relates to child welfare. And my goal today is sort of to set the stage. And I wanted to well, there we go. This is, the CDC's MMWR that highlighted what was just mentioned. And we know so much about syphilis. We know the biology of it. We know how to treat it. None of that has changed. Yet these rates speak to the fact that this is not a scientific question per se. This is a societal kind of issue in question. And they stated here that substance use prevalence has increased among women with syphilis, which is a rather simplistic way to kind of think about the syndemic and about causality. So one thing that I want to focus on is how sort of the relationship between syphilis and substance use in the context of pregnancy, specifically how both are reportable. That syphilis is nationally notifiable via the NNDSS, and the requirement for reporting certainly varies by state, and that has a synergy with the reporting requirements of substance-exposed newborns. And that reporting requirement for substance-exposed newborns, or the perception of that, I think influences how people legitimately approach prenatal care, and how providers interact with people who are pregnant who use drugs. So the federal guidance, the federal statute around mandatory reporting is codified in CAPTA, the Child Abuse Prevention Treatment Act, which emerged really from the ashes of something called the Comprehensive Child Development Act, which was vetoed in 1971 and was a bipartisan effort to provide federally funded, universal, affordable early education and childcare to families across the United States. And that vision was repackaged federally to become CAPTA, the mandatory reporting for child abuse. What Marty Guggenheimer has stated, this is when the federal government went from a comprehensive response to child poverty to pathologizing poor parents as potential child abusers. And the same administrative urgency that was written into the law federally and has been reauthorized, and as every state has its own compliant statute, I think creates a real false urgency around drugs. If you have a child who's being potentially abused at home, acting quickly is important. If you're responding to a positive drug test that was done during the birthing hospitalization, that response, that urgency is actually false and harmful. And it should be noted that drugs were never part of the original language in CAPTA. And it was only following the hysteria around crack babies that subsequent amendments to CAPTA included drug exposure as part of mandatory reporting. And we now have 10 to 15 years of data that look at the population health effect of punitive policies in general and mandatory reporting policies in particular. And by punitive policies, I mean not just mandatory reporting, but states that codify substance use in pregnancy as child abuse, and also states that can coerce or mandate treatment, for pregnant individuals. And we know that these punitive policies in general show no improvement in birth outcomes on the population level. In fact, they're associated with an increased odds of neonatal abstinence syndrome, and increased odds of low birth weight and preterm delivery, and a decreased odds of any prenatal care. And whereas drug policy in general has bent away from the punitive nationally at the state level, policies specific to drug use in pregnancy are becoming increasingly punitive. And that's changed the landscape of child welfare, in particular for infants, people under the age of 1. And today, parental substance use is the leading cause for child removal. Rates range across states, but it's the leading cause. And the leading driver of this are actually health professionals. There's been no change in reporting from anonymous sources, family, police, or schooling, but there's been an over 400% increase of reports to child welfare originating from health professionals, driven to a large extent by the misuse and misinterpretation of drug tests. And this has compounded existing racial inequities. As you can see here, these are rates of infants who are screened in by child welfare, reported from health professionals over time, and an increasing rate of screened in individuals, both Black and Indigenous children. And I'll say that health professionals do not understand really what the child welfare system is, what happens following a report. And this is, a sequence of events that happen over usually a determined timeline, that decisions around, foster placement determination have to be concluded within, 18 months or 24 months, depending upon the state. And those timelines don't always line up with people's recovery. And something I just learned rather recently that I did not know before, but that when a person's parental rights are terminated, the birth record is rewritten and the birthing person's name is removed from that document and the adoptive parent is placed in that place. And so our patients actually understand structural inequities probably better than we do. And there's a large literature, both qualitative and synthetic, that looks at the consequences of child welfare reports, separations, and termination of parental rights, that demonstrates sort of an increased burden of behavioral health comorbidities and return to use for people who use drugs amongst those who lose their children to the system. And one of the motivations, for a child welfare report from a health professional is, I see this family in front of me. They need services. I don't know how to provide those services, but I want to report them to a system that I think might be able to. Or another motivation is, I can't attest to the safety of this individual at home. I'm better safe than sorry. And what I think we don't recognize as physicians is that the report doesn't lead to safety. 20% of children experience abuse or neglect in out-of-home placement. We know that mental health and somatic conditions are greater among children in foster care compared to the general population. Children in foster care experience toxic stress, which is defined by the American Academy of Pediatrics as the physiologic result of physical, dangerous, recurrent, or prolonged experiences of trauma caused by the initiation of a stress response without the protective existence of a compassionate adult. And both children and parents have expressed non-death loss and grief following foster care placement. In many ways, like this paradigm of report is grounded in sort of this sort of misinformation and this sort of false ideology of substances. Our classification of substances, prescribed, legal, and illegal, is a legal and social classification that does not apply to biology or to public health, like, burden of harm. And the assumption that illegal substances are more harmful is frankly unscientific. From the perspective of teratogens, substances that can cause birth defects, all of the known teratogens are either prescribed medications or legal substances and not illegal ones. So I think when we think about sort of how carcerality has entered into the care system, we can see how care becomes corrupted when we are requiring health professionals, as ACOG calls out here, to act as agents of law enforcement. And the American Society of Addiction Medicine has stated that equating a positive drug test with child abuse or neglect is scientifically inaccurate and inappropriate, and can lead to an unnecessarily punitive approach which harms clinician-patient trust and persons' engagement with healthcare services. So we know that in the United States, we have increasing rates of maternal death in contrast to most, of the rest of the world. And we know that birth is no longer safe, and it's in particularly not safe for people who use drugs. And so throughout the following presentations, we're going to hear about the stigma and discrimination that people with substance use disorder face when they encounter healthcare systems. And I would encourage us to consider discrimination as a patient safety issue, to sort of plug our response, our QI projects, as addressing discrimination as we have addressed other, maternal health outcomes. And part of doing this has been here on the left-hand side. We're going to hear from Lauren Pauck in a bit, who put together this wonderful resource with If, When, How that actually identifies what the state laws are. And contrast that with the practice that happens in most birthing hospitals. We tend to over-report, to child welfare in excess of what the legal mandate is. And on the right-hand side, this is a course that Lauren and I and other people developed with a QR code here, if you're interested, that really is about trying to educate health professionals about what the child welfare system is, what alternatives are to reporting, what a drug test is, and et cetera. So in conclusion, I think we need to think about child welfare as a structural determinant of ill health. And from the perspective of this syndemic, I'd like us to think about how mandatory reporting for substance-exposed newborns actually directly interferes with our public health response to congenital syphilis. So with that, thank you. And I'm turning it over to Andre.
Thank you, Mishka, for an excellent talk as always. And I'm so honored to be here with everyone today. And I'm going to continue to set the stage a bit. So my name is Dr. Andre Jones. I'm a psychologist and a PhD at the University of North Carolina in Chapel Hill. And I've had the honor and joy of being able to take care of pregnant and parenting individuals that have substance use disorders and their children. And so I want to continue to ground this conversation to make sure that we are all level set in what we are talking about today. And so I want to do that by talking about what is a substance use disorder. And so our Diagnostic and Statistical Manual 5, which has been around since 2013, has 11 signs to determine the extent to which someone has a substance use disorder. So it's very important for us to remember that just because someone might have a urine or other biological tox screen or test that is positive for a substance, that is not a diagnosis for a substance use disorder. All that is telling us is that there is evidence in that person's biological test that they have used substances in some period of time that that test detects. And so when we're talking about substance use disorders, we're going to be talking about people that have behavioral changes from the response of their drugs. So that means the patients that I work with, they have missed obligations. They have lost jobs or had trouble fulfilling their job obligations. They have emotional problems with their partners, with loved ones. They have relationship problems. They have tried so many times to stop their substance use and not been able to. They say, I'm only going to use one or only going to drink something, and then they end up using much more. So they use more than they expect to use, and they spend so much time of their day looking for substance, using that substance, and then recovering from that substance. We also, to define a substance use disorder, there's also the hazardous use. So that is driving a car or a motor vehicle under the influence, or perhaps having a major health problem like lung problems and still continuing to smoke cannabis, for example. And if you'll notice, all of the ones that I just shared are behavioral signs. They are not physiological signs. The only two physiological signs that we have of substance use disorders are our tolerance, which means that's you take a drug one time and you get an effect, and then you take that same amount the next time and you don't get the same effect. You get a less of an effect, so you have to take more. So you build up your tolerance. And then withdrawal is that opposite effect of the drug. And if you talk with any person that has been using opiates for any period of time, they know what that withdrawal feels like, and it is terrifying. The idea of feeling like flu symptoms, the goose flesh, the just feeling terrible, you get the runny nose, the eyes, everything. And so we have a severity of substance use. And we know sometimes that the behaviors that our patients exhibit to us can be very frustrating for healthcare and behavioral health professionals. And what I ask you to do is, rather than feel that frustration or act on that frustration, I ask you to take the opposite approach and recognize that the behaviors that people are expressing are a call for more help and support. I also want to emphasize that over 40% of adults that come into treatment that report to us that they have started using substances under the age of 14. So I want to underscore that substance use disorder is a pediatric illness. And so when we talk to our patients, again, to level set, what is a substance use disorder? What are we talking about? We have to think about dopamine. So we know that certainly we need food to survive, we need water to survive, but we also need dopamine. And so if you're listening to a lecture on having an average day like this one, you've probably got about 50 nanograms per deciliter of dopamine in your brain. If you have a fantastic day, you win the lottery, everything's going your way, you might have 100 nanograms per deciliter of dopamine in your brain. But when you take substances, that can overwhelm your brain with dopamine, which it feels amazing. What can also happen for patients that have severe substance use disorders is that there's less and less availability of dopamine in their brain. So for example, the patients that come to the UNC Horizons program have on average about 10 nanograms per deciliter of dopamine in their brain. What does that mean? That means they think they need that drug to survive. Their brain craves that drug. And when we get severe craving, we're going to jump into survival mode, which means that oftentimes we need to do things, break every promise, break every value in order not to feel good, but just not to feel sick. So I want to just remind us about our patients when they come to us that often they have no other choice. They have no other option, and they are scared. And it is our job to earn their trust. If you want behavioral change in patients, if you want people to take medications for syphilis, to come and repeatedly get screening, get tested, and continue to bring their infants, they have to trust you. And we know that since 1971, since the first time we started asking patients about what keeps them from prenatal care, it is fear. It is fear of the healthcare providers themselves. It's fear of loss of custody. It's fear of, I don't want my child to be taken away. I don't want to be separated from my child. And certainly concerns about stigma and privacy. I can't tell you how many patients have told me, I walked in, they found out I had syphilis, they found out I was a substance user, and they treated me differently. They looked at me differently. The words that they used were different, and I didn't want to go there for care anymore. I actually did not seek care because of the way I was treated in healthcare. And so what can we do? We have these intertwined challenges, right? We have an increasing rise of syphilis, as we've heard, an increasing rate of methamphetamine and opioids. We know that our drug supply is poisoned every day in this country. It has become more deadly to use substances. And when we see more methamphetamine use, we also see a rise in syphilis. And we know that many of our patients that need to do things to survive, to have money, they will engage in sexual activity. So we have to take that into account. We've got to get rid of the shame and the blame, and we need to help support them in making the best changes that they can for themselves and for their babies. And so when I give talks, I often like to ask patients, what do you want providers to know? And these are some of the things that the patients told me. For example, say that drugs are really common in our society, and we aren't here to judge you, but we're here to provide you with answers. Tell us up front what's going to happen to the information we share. That includes syphilis testing, syphilis medication, as well as screening for substance use disorders or substance use. Is everybody in EPIC going to see it? Tell us what you're going to do before you ask us those questions. Please consent us. And if we refuse, please don't assume the worst of us. When you ask for our consent, it actually makes you think that that makes me think that you are helping and you're taking our answers seriously and you're going to do something. And that was something too that patients said is don't just screen us if you're not going to act on it. Don't tell us we know you need help, but we don't know where to send you to get help. And when you talk about the importance of catching health issues early, like syphilis, like substance use disorders, that helps us know that we have more time to make changes. This is an example of a journey map that was done at Mass General for children. And so you can see here, this is just another example of all the different ways that our patients have to fight up against the system in order to receive the care that they deserve. One of the things that has really struck me most recently is the idea that behavioral change happens at the speed of trust. So what do we need to do to earn our patients' trust, to be honest, to be transparent, to help work within the system while we change the system? But you can see here in this journey map how there's the stress, there's the stigma, there's the fear, the loss of privacy, the loss of ability to make informed decisions. Patients in many systems, they take a methadone or a buprenorphine that is what is prescribed by their physician, their provider. They're doing the best they can for that baby and for themselves. And yet they encounter mandated reporting. So now they are punished for doing the very thing that was keeping them alive. We know we have great data with regard to taking a medication during pregnancy like methadone or buprenorphine and not having an overdose or a fatal overdose. So the end of this is we can create a better path. There is absolutely support that can be done. A couple of tips, again, that patients had shared with me about the intersection between syphilis and substance use disorders is make sure that you have a fund for copays. If we don't have the money to pay for our medication, even that small amount for copays, we're not going to get our medication. So what can you do to help support us? The way you talk about syphilis is just as important about how you talk about other health conditions. Please don't judge us. Please, if the medication isn't available, and we know that so many patients have struggled with medication access, take the extra step as that provider. Call the pharmacy for us. Find out where that medication is so we can get it. Recognize the reality that we might have to engage in sex work to survive. So what can you do in a harm reduction approach to help keep us and our clients safe? And also think about that syphilis reporting and who is finding out this information and what is the experience or increased risk of violence towards the patients that we are taking care of. And then finally, in terms of solutions to reverse maternal mortality, as you know, in the United States, we have a growing rate of maternal mortality. And right now, the best of my knowledge, we are not working towards the WHO, or we're not enacting the WHO recommendations, which is at least 4 healthcare contacts postpartum in the first 6 weeks. So typically we see a person one time and then it's 6 or 8 weeks and see you later, good luck to you. So we also need to do a better job of having trauma-informed, culturally appropriate care to address the different issues that our patients face, including mental health, suicide risks, and personal violence. And finally, as Mishka had already alluded to, and I know we'll hear more about, is reviewing and changing those hospital policies and state policies that prevent care. So what can you do? You can be honest and transparent with your patients. You can take care with your words. You can set up a fund to make sure that they have access to their medication. Make sure that you are telling stories of success and recovery. There are so many patients in this country that want to tell their stories of success and deserve to be highlighted and deserve to have the microphone. And finally, just a reminder that Narcan can be used for all ages and that it should be co-prescribed wherever we have patients that have substance use disorders, and it can be given to their families. Thank you so much. and I'm going to turn it over to Caitlin.
Thank you, Andre. My name is Caitlin Martin. I'm an OBGYN addiction medicine provider like Ms. Turplin. I am here in Virginia Commonwealth University in Richmond, Virginia. And actually, before my presentation, where I'm going to talk about just an example of what we do here in Richmond, Virginia, just to give you some practical, just one example of real life, how we take care of pregnant and parenting people with substance use disorders. But before I go into that, we're going to have a video from a person with living experience. I don't hear the sound. Back up.
My name is Leah. I'm 35 years old. I have 4 beautiful children, 2 of which I have been in a methadone treatment facility since March of 2019. One is 3 years old, and our newest addition, Luna, is 3 months old. Struggling with addiction has been very hard. It was my older children lost their father, and that's what pushed me into using into the substance abuse, and that lasted for 4 years. And then I went to the treatment center and got help, and then I got pregnant very soon after that. It was very scary. It was new. The recovery process is hard in itself for me as an individual. I'm a mom. My children are 16, 12, 3, and 3 months old. So they range in age, and the struggles of every day, staying strong, having a great support system. It's hard in itself. To be pregnant is even more hard because it's just uncharted territory. And come to find out, it's not just for me, it is for the healthcare providers as well. It is a learning experience all the way around, and I understand that. I knew that going into it.
Thank you. And I also like to thank Leah for making those videos with me. I'm very appreciative for her. So like I mentioned, I'm going to be following the last 2 presentations talking about an example of our program that we have here at Virginia Commonwealth University in Richmond, Virginia, where we really do strive every day, my team and I, to operationalize compassionate, trauma-informed, evidence-based care for pregnant, postpartum, and parenting people with substance use disorders. This is not meant to say that this is how everyone else should do, but I just wanted to give an example of how we are doing that here, boots on the ground in Richmond. So our name of our program is OB Motivate. And so what we do is that we are an integrated care model. So here's a picture of our small but mighty team. And so me and along with another medical provider, we are both OBGYNs who do addiction medicine. So we're kind of a 2-in-1, but we don't necessarily have to do that all the time. And we have a nurse, a care coordinator, a social worker, kind of that makes up our core team. And what we do is we integrate medical care, the things that we can provide as OBGYNs with regards to care across the life course for sexual reproductive health, including prenatal and postpartum care. We also provide addiction treatments. So that includes medications that we can prescribe in the outpatient setting, such as buprenorphine for opioid use disorder and other medications for alcohol use disorder. And then in addition to that, we focus on linking our patients whenever they need services for other areas. So our social worker does a lot to interface with our patients, to link them to resources here in the Central Virginia area with regards to housing, if we need a higher level of care, food insecurity, etc. And we also link with the behavioral health clinicians that we have here at the VCU campus to provide both group and individual counseling services for our patients. And you're probably wondering, well, how do you do that? Sometimes it's hard to fund these things, find money, and also find the people to do this. What we do is we rely on making connections with other people and other groups across our campus and also across our community, most importantly. And we also integrate a lot of trainees. I feel very passionate that we need to equip the next generation of providers across medical and other areas of medicine and healthcare. In the proper care for the disease of addiction, and also in the compassionate evidence-based care that we really need to catch up on when we're talking about substance use disorders. So what we do is we partner with different groups that maybe have trainees that need to have a placement, for example, that's focused on substance use. So the trainees are the ones who are boots on the ground providing the services with the supervisors who are available. And so we have about 200 patients at any given time that we're providing care for that kind of come and go. And the bulk of those patients are either pregnant or within the first year after pregnancy. And so when you think about addiction treatments, there's these levels of care that we talk about. There's things from a kind of an outpatient-based setting, and that's what OB Motivate is, all the way up to higher levels of care, which is kind of a buzzword that we use in the addiction medicine field. That's things like residential treatment centers. And so just one example, OB Motivate, we call ourselves small but mighty. So we are, again, that outpatient-based service here in Central Virginia. We are trying to follow a hub and spoke model and working towards that more and more, and partnering with other OBGYN and other prenatal care practices, as well as other addiction treatment centers in the Central Virginia area and partnering with them in order to provide this integrated care and also just comprehensive care, even if it's fragmented between different clinics by geography. We do partner with our Virginia Medicaid program, so we are able to take advantage of the reimbursement programs that they do have in our state that does allow us to bill at an appropriate level and keep our doors open, like I like to say. And like I mentioned earlier, we do provide evidence-based treatments, including medications, and we do offer comprehensive care services, like I mentioned earlier. And I'm going to talk a little bit more about some of the specifics of those services in the next couple slides. One of the multiple tenets of our program, I mentioned our title alone had a lot of things about OB Motivate and our mission. But one of the other areas I would just like to emphasize is that we truly try our best within the systems that we work in, which have a lot of systemic and structural barriers and silos, but we do what we can within those systems that we work in as an outpatient-based program to meet our patients where they are instead of forcing our patients to meet us where we are. And so one of the ways that we operationalize that, again, we are not perfect, but one of the ways that we try to do that is that we have 3 different, quote, geographic locations, and then we partner with collaborating clinicians in other areas, thinking about, gosh, where are our patients going to touch the healthcare system as they're going through the trajectory of pregnancy and postpartum, as well as going through the trajectory of recovery? And for us, a lot of our patients are going to touch the healthcare system on both the outpatient and inpatient setting. The inpatient setting is, of course, going to be that delivery hospitalization, or if they need to have an admission in the antepartum or prenatal period, or in the postpartum period due to a medical complication, which is inherent to pregnancy. The other areas that we work on is we have clinics. We have a clinic that is integrated geographically into the OBGYN clinic here at VCU Health. And then we have another location where our same providers, same nurses go, that's integrated within the psychiatry department in an addiction medicine clinic. And then lastly, our patients do interface with local jails a lot. We have a lot of patients that go in and out. And again, we try our best to meet patients where they are. So we go to one jail and then we partner with multiple other local jails for patients. And we are able to do that for our pregnant patients currently, who we can partner with them to make sure that they're still getting evidence-based treatments for opioid use disorder, as one example. And so I mentioned all these things that we do, and I mentioned a little bit of how we find the money to do that. But I really want to make sure that I'm not giving the point away that gosh, these patients who have a lot of needs, both medical, the topic of this talk, for example, today is syphilis, which is something we definitely screen and treat our patients for and meet a lot of barriers in doing so, which I'm happy to answer questions about, as well as from a substance use and a psychosocial perspective. But please know that I am not saying that a kitchen sink approach is what we should be recommending for these patients, nor should be any type of policy that we should be having at a clinic level. And from our clinic here at OB Motivate, we got some data to back this up. So we looked at a list of all the things that we offer, and that's in this fancy graph here in the bottom of the slide. We kind of just took all the services that we offer and we kind of chunked them, and we looked to see, gosh, do our patient outcomes differ based on, gosh, how many services our patients took advantage of or engaged with during the prenatal and postpartum period. And what we found is that when you just have the services available that we know are evidence-based, and you make those services available in a compassionate way, and you make those services available coaxed in a harm reduction model that really tries to meet patients as much as you can within the structures we work in, meet patients where they are rather than having them meet you where you are, you can get good outcomes across the board. You don't have to force patients to have a kitchen sink approach or have a long list in order to meet the outcomes that we all want, which is better health and quality of life outcomes for our families. So as I end, I just want to also plug what everyone else has already talked about, is that harm reduction is a key ingredient when we're talking about care for patients with substance use disorders, especially when we're looking at the interface between pregnancy and postpartum. And I would really like to echo what was already said about when we're talking about the rise in syphilis rates in our country today, and how harm reduction really needs to not be something that we ignore going forward, and that we really need to think about how we can continue to integrate harm reduction into the comprehensive care that we provide for all patients, I would say, in the prenatal and postpartum setting. I would just like to say that as an OBGYN, harm reduction is really easy for me, right? I was trained in birth control and condoms, right? And expedited partner therapy for STIs, et cetera. So as a provider who was trained in reproductive and sexual health care, this is inherent to what I do. But I will say that it's not obvious how to translate that into the substance use world. We weren't trained in how to do that. And so we really need to catch up when we're looking at this syndemic today on how we can catch up to the providers who are out in practice, and also equipping the next generation with how to incorporate harm reduction into their practice. And so I'd like to end here and also end with a video from Leah before we go on to the next speaker. Thank you.
From the doctor at my treatment center, to my OBGYN, to the NICU doctors that took care of Luna after she was born, the knowledge is not there. I'm a test subject. We are test subjects, to put it in, I hate to say it that way, but that's how we feel. That's how I feel personally. That is terrifying, that the people that our lives are in your hands, and you don't even know what to do when it comes to a situation like that. There is there's a lack of knowledge. There's a lack of data. There is, and nobody wants to take that extra step to educate themselves further. They don't. So when you have a pregnancy like mine, and I had all these issues, that's just one team of doctors right there. Are they sharing that? Are they taking that data into effect and sharing it for the next person? Because if they're not, then none of this is going to get better. It's just going to stay plateaued, because there's no one trying to educate themselves more. They look at you like you're a junkie, statistics. And it's hard. It makes us not want to be open about our recovery, our addiction, and where we're at. It's difficult. And these are the people that I trust my life with, and my child's life with, and I would just love to see and it's not their fault. Again, it's a learning experience. And I knew going into my OBGYN that it is a learning hospital. And you don't know until you experience. You have to go through it. But how many patients does it take to go through it before they put that data on paper so the next person knows? It shouldn't be more than just one. It should only take that one.
Okay, I think I'll take over from here. My name is Melanie Taylor, and I'm going to be presenting today and sharing best practices and challenges also to delivering a coordinated syphilis response at a community level. Now, specifically, I'm going to be presenting on behalf of the Indian Health Service, and I'm going to be describing approaches for American Indian Alaska Native people at risk for syphilis. I'm a physician. I work for the Centers for Disease Control and work closely with the Indian Health Service. And today I'm going to be talking about opportunities to address substance abuse through a syndemic approach with a specific focus on syphilis. Now, as background, let's see. There we go. It's a little bit of a lag. Now, as background, as was presented earlier, in 2022, CDC reported the highest rate and rate increase of reported adult infectious primary and secondary stage syphilis occurred among non-Hispanic American Indian Alaska Native persons. This is abbreviated AIN and it's in the dark line at the top. In 2022, similarly and alongside, the highest rate of reported cases of congenital syphilis or mother-to-child transmission of syphilis also occurred among mothers who were American Indian or Alaska Native. Underlying these risks and rates of congenital syphilis among American Indian Alaska Native people are several issues related to social determinants of health, behavioral risks, as well as medical care access. Specifically, the criminalization of substance abuse disorder during pregnancy can be a specific and acute barrier to patients who are pregnant seeking prenatal care. And we've heard that from some of our other speakers. There's fear of reprisal, which can be associated with criminalization, reported child abuse, reckless endangerment, and in the involvement of child protective services, influencing the custody of an infant at the time of delivery. Now, for American Indian Alaska Native patients who are pregnant, this is a very special risk because American Indian Alaska Native patients fall under tribal law as well as state and federal laws, depending on where they seek their OBGYN care and where they deliver their infant. In addition, due to clinical staff shortages of OBGYN providers, the demands frequently do not meet the need for prenatal care, and women may need to seek and often seek prenatal care off their tribal lands and very far from their homes. And finally, limited or lack of data sharing from states to sovereign tribal nations has hindered the tribal public health responses to communicable disease increases, and in this case, syphilis. A couple of success stories here. One tribal nation has successfully removed tribal laws that criminalize substance use in pregnancy. And in other tribal areas, tribal nations have obtained the rights to state data access in order to deliver a coordinated public health response to syphilis in conjunction to substance abuse and to deliver substance abuse treatment. Now, foundational to the delivery and response to syphilis is the need for treatment with the only drug recommended for treatment of pregnant women with syphilis, and that's penicillin. The national shortage of benzathine penicillin has affected the public health response to syphilis nationally and the increases in the United States. However, the Indian Health Service has ensured that an adequate supply of benzathine penicillin is available for tribal health facilities, IHS service units, and others receiving care through tribal health facilities. Now, what I want to make clear is that we must get the medication to the patients who have syphilis. We must get the testing and treatment to them where they are. Now, the U.S. Preventive Health Services Task Force and CDC recommend universal syphilis screening during pregnancy, but they also recommend syphilis screening among patients who are at risk, those non-pregnant adults and others who are at risk. What I think it's important to remember is that the Indian Health Service recognizes the high rates of adult and congenital syphilis, and as an update and as an expansion, IHS recommends for American Indian Alaska Native people seeking care through IHS tribal and urban health facilities that all pregnant patients receive 3 time point screening. That is in alignment also with CDC, and that is at first prenatal visit, again at the 3rd trimester, and again at the time of delivery. And IHS also recommends universal screening for all populations seeking care in IHS facilities, tribal as well as urban. And this is to all persons ages 13 and older and includes anyone entering emergency and urgent care settings. So these expanded recommendations are really important because they also recognize the syndemic approach and the recognition of substance abuse as a contributor to the sexual risk for not just syphilis, but other STIs as well. And this syndemic strategy, this is in alignment with the indigenous syndemic strategy for HIV, STI, and hepatitis, and specifically IHS uses a syndemic bundle. And what that means is that when a patient presents for care, we don't just recommend testing for syphilis because there's an outbreak, but we recognize syphilis in the company of other STIs and sexually transmitted conditions by which pregnancy is sexually transmitted and should be included and is included in the IHS syndemic bundle for testing. As additional best practices, it's important that we not forget HIV during this time period of syphilis increases, and patients that are using substances are specifically at risk for HIV acquisition. And as a best practice, pre-exposure prophylaxis for HIV prevention is recommended for patients who have other STIs, and we do recognize the very high risk among patients who are using substances. To continue the discussion and presentation of best practices, one of the things that's very difficult for patients is having to make an appointment. And IHS now recommends and is implementing express STI services that increase the clinic capacity, that expand the ability to use fewer providers, and that allow patients to walk up and request STI testing without an appointment, without a clinical exam. And this expedited care model actually facilitates on-demand care when the patients are ready, when they are ready to seek services. And it is much more accessible to patients who are using substances who may and are likely not oftentimes enrolled in primary care. Now, in addition to that, there is the opportunity to bring treatment to patients where they are. And this is a critical thing for syphilis. It's not just about ensuring that they are treated, but bringing that treatment to them and providing injections of benzathine penicillin outside of clinical settings is an IHS best practice, and it allows for adequate treatment of patients with substance use disorder and also pregnant patients who may also be challenged with other childcare responsibilities, lack of transportation, and also substance abuse concerns. So this field treatment can really overcome barriers related to transportation and privacy concerns in seeking healthcare at small community-based service units, and public health nurses employed by the Indian Health Service and also other medical providers in IHS can perform these field injections to bring that treatment out into the community and even in patients' homes. Now, one of the things that's important to remember is that we don't always need a positive test to treat a patient with benzathine penicillin. If we assume or we presume or we suspect syphilis due to the presentation of symptoms, we're not talking about syphilis symptoms today, but those patients who have typical symptoms of syphilis can be treated presumptively, as can their sexual contacts. They can be treated in the field, as we've already presented. And in addition, those who are being tested and found positive with a rapid test. And this also expedites treatment, allows for more complete treatment, and is really a best practice that we hope others will consider, especially when we know that patients using substances may oftentimes not present for treatment. I can't really stress enough the importance of contact tracing here to control community level transmission of syphilis. And it is a top level best practice for syphilis control and halting epidemics, particularly in small communities like those in tribal areas and American Indian Alaska Native populations. And this public health practice is the most effective way to identify undiagnosed syphilis at a community level and to find, identify, refer, and treat contacts presumptively to stop community level transmission. And that means that we need to have an adequate workforce. We need to reimagine that workforce, and we need to preserve the public health workforce that is performing contact tracing if we truly want to stop the syphilis epidemic. Now, continuing along and in the same line, it is important that we recognize the need to train further more persons that are working in tribal health areas to perform contact tracing. And CDC offers training for health departments to learn and deliver contact tracing, also known as partner services when we're talking about STIs, is that we need more folks who are doing this work. Unfortunately, those who are working in COVID have since moved on. Funding has dwindled, but we do need these in-person contact tracers to identify partners and bring them in for treatment. Now, moving on, we also need to recognize the really critical need for adult and infant case management, and that needs to have at the priority point data sharing across public health partnerships. And that data sharing was a barrier that I presented earlier. It needs to be an opportunity for us to bring together state, tribal, territorial, and IHS partnerships to do comprehensive and coordinated patient care, and that includes contact tracing. That communication and coordination is really critical for outbreak response. Now, something that's innovative are patient incentives. These can be very helpful for patients who are using substances and are part of substance abuse recovery programs to incentivize them to continue their substance abuse recovery, but also for other communicable and non-communicable infections where we need for patients to present for care that includes testing and for them to present for completion of treatment for syphilis. And we've had positive response in using this patient incentive care program in the Indian Health Service, and it is usually in the form of gift cards where patients may be able to purchase groceries or gas money for transportation. Now, provider education is also paramount within all healthcare providers that are seeking increased awareness and understanding of syphilis. Syphilis is difficult. That is a difficult infection to diagnose. It's difficult to recognize. The testing is a bit confusing, but what's important is that we provide the best resources possible, and we ensure that providers have the best education, awareness of substance abuse disorder, and they offer an integrated approach to both treatment of syphilis and other STIs, prevention of HIV, but also treatment of substance use disorder. And this is really quite critical. Now, as a final best practice, I want to speak to the education of the community level persons who are at risk and who may be able to deliver that knowledge to other persons in their families and communities. Best practice, again, is community awareness and letting patients know of associated risk with vertical transmission and risk associated with untreated transmission of syphilis as well. And it's really an integral part of the syphilis response. And these educational campaigns can, of course, be linked to substance use treatment services as well. And finally, I want to leave you with the need to build a coordinated and effective response. And this slide really summarizes some of these best practices, but also challenges. And it's kind of a matrix really for a holistic approach with high-level challenges at the top that include and other building blocks for best practice using multi-partnership. And this multi-partnership specifically for syphilis, but eligible and applicable broadly. This includes reimagining the workforce, as I mentioned, to ensure contact tracing is an integral part, and also to make sure that we engage the communities that are affected so that they can be part of the solution and to provide the education that's really needed for this type of success. Note that at the top, we have the congenital syphilis challenges related to the opportunities for prevention, and those are related to social determinants of health, such as poverty and access to healthcare, as well as those barriers that we talked about earlier that are related to the criminalization of drug use during pregnancy. And we really need to provide the care and treatment for substance use disorder as we address syphilis. And we recognize that syphilis is oftentimes a societal symptom of a much bigger range of challenges for which syphilis becomes what's noticed first. And then we also recognize that all of these risks and challenges and determinants of social health can truly threaten a pregnant woman's access and consideration of uptake of prenatal care services. And we want to recognize all of these as opportunities and not just barriers, but really to work towards the success and syphilis control as a coordinated response, recognizing this as just one communicable disease in the syndemic of STIs, HIV, hepatitis, and substance abuse disorder. I'd like to thank you and thank you, the conference organizers today, and also recognize and appreciate the images that were shared with me through IHS, the Northwest Portland Area Indian Health Board, and the Raven Collective. Thank you all. And I will hand over to Rebecca. Thank you very much.
Our next speaker is Lauren Polk.
Hi, everyone. I'll go ahead and introduce myself while I'm waiting for my slides. Oh, there they are. So I'm so honored to be here with you today. Lauren Polk, she, her pronouns, and I am the Senior Research Counsel for If, When, How. We have heard some amazing practical on-the-ground responses, and so I'll be taking a step back to focus today on some policy solutions that we can use to tackle this syndemic head-on. So my work at If, When, How really focuses on the intersection of mandatory reporting and pregnancy criminalization, and includes both legal research and talking directly to healthcare providers about these issues. If, When, How provides both direct legal services and policy advocacy on a variety of issues related to pregnancy and access to confidential healthcare. Before I jump into policy solutions, I do want to acknowledge the advocates and activists who have helped pave the way for us to get here today, including Dr. Mishka Turplin and Dr. Sarah Roberts, who have been immeasurably helpful in my learning around substance use and during pregnancy and how policies can harm families. Movement for Family Power, Dorothy Roberts, and many systems impacted parents have shown me the very real harms of family separation. And I also want to thank Andrew Yu from IHS for helping inform my understanding of policy creation and impact in sovereign tribal nations. So my colleagues who spoke before me have demonstrated that there is a great deal of fear on behalf of patients using substances who seek medical care during pregnancy, and that's for good reason. The specter of mandatory reporting hangs over medical care in this area so heavily that we are now seeing an uptick in very preventable diseases like congenital syphilis, due at least in part to these policies. I want to start on the micro level with what individual providers can do to help combat the public health issue that is family separation and substance use during pregnancy. So first, I want to talk about genuine informed consent. So informed consent really helps protect the patient-provider relationship. It's a fundamental legal and ethical responsibility, and true informed consent really requires sharing the full explanation of the consequences of certain medical care with a patient. And that full explanation includes the legal consequences of things like testing, screening, and potentially reporting patients for substance use during pregnancy, and sharing that they have the right to refuse certain tests. I also want to point to medical records. So medical records are often used against parents and their families in child welfare investigations and cases. So including positive observations of a family in the medical record can be protective of your patients. And some examples of helpful observations to chart can include helpful information about the steps that the parent took to obtain prenatal care and make a birth plan, information that you might have counseled the family on and their positive reaction to that patient counseling and feedback, observations that you make or information that the family shares that specifically mitigates the alleged risk in the report, such as discussing treatment options and the patient's very open to finding the right provider, or the patient has a very supportive parent who will be staying with the family for the first 3 months after birth. And additionally, positive observations and a lack of safety concerns for older children as well. So saying that the child appears healthy, well cared for, and no child protective concerns. If you are legally required to report, but you wouldn't if the law didn't exist, explaining in the abuse or neglect report that you don't have child protective concerns and you're reporting simply because of state requirements, and not including or disclosing information about the family that doesn't need to be reported. So I'm thinking about medical diagnoses that are irrelevant to the report and private. And speaking of that, being wary of HIPAA violations, right? So giving information, private information about a patient where that is not warranted or not allowed under law might cross that line into a HIPAA violation. And then additionally, you're not legally required to speak to the police or to child protective caseworkers if you're a healthcare provider. The law doesn't require you to provide police or child protective caseworkers with medical records absent a subpoena signed by a judge, and doing so could be extremely harmful to your patients. And lastly, if you do have to make that report, helping to prepare the family. So letting the patient know that you or someone else on their care team made a report, followed by what they can expect from the investigation, which is why calling back to what my other panelists were talking about, it's so important that healthcare providers themselves understand what happens in the course of a caseworker investigation. And if you do have questions about that, you can contact If When How. Our email is technicalassistance@ifwhenhow.org, and I'll pop that into the chat after this. Assisting the family with safety planning, including sharing resources that might preemptively address the state's child welfare concerns, and ensuring that the family has a copy of the discharge summary or a signed letter or document that includes the positive information we talked about before, and that you are the treating provider, and a description of their follow-up plan of care, or that you have no safety concerns and there's no need for follow-up care. I also want to add cultural competency is extremely important for all healthcare providers, but it's especially relevant when we're talking about healthcare providers who are not Native, providing care to Native communities. So knowledge of how to best care for the community you're serving might very well be the difference between someone getting services and someone not getting those services. So once providers have solidified their own personal policies, it's time to advocate for department and hospital level policies on substance use during pregnancy. So first, there's no need for hospital policy to go beyond what state law requires for drug testing and reporting. The CAPTA resource that we shared earlier from If When How is a good resource for understanding what the law actually is in your state. Many hospital policies on drug testing are based on outdated science on substance use or just an incorrect understanding of what the law requires. Working with policy setters at the hospital level might be as simple as sharing the updated science and legal requirements with the hospital, or it might be an uphill battle against traditional practice. Either way, you don't need to go it alone. If When How, again, offers technical assistance on changing hospital policies, and because of the Doing Right at Birth cohort, we can likely get you connected to a mentor who has also fought to improve their hospital policies. Second, as I mentioned at the micro level, medical records can be utilized to harm patients. So having clear hospital or departmental policies around what should and shouldn't be documented in a patient's medical chart can be protective. And it can also give everyone somewhat of a North Star when they're doing their charting. Third, it's so important that hospitals have clear policies around police interaction. The laws governing sharing patient information, like HIPAA, with police can give some guidance, and HIPAA only requires sharing information with law enforcement when there's a legally enforceable order, like a search warrant or court order that forces a medical professional to turn over information. And even then, it's very important to work with an attorney so that the information that you do give to law enforcement can be redacted to a version that's really narrowly tailored to the requirements of the order that they're seeking. Healthcare should not be a site of policing. Blurring the lines between policing and care is part of the reason we're here in the first place. Patients should really be able to seek healthcare without that fear of criminalization. Fourth, I would encourage you to find colleagues that are values aligned and you can support one another, creating department level pods so that when tough situations arise, you have peer support to talk them through and get through them. In many instances, hospital legal counsel can be a help and a guide in tough scenarios, but providers would do well to remember that it's literally the hospital counsel's job to protect the hospital from liability, and different lawyers have different interpretations on how best to do that. I know that doesn't make your job as healthcare providers any easier, but it's worth keeping that in mind as part of your patient advocacy plan. And fifth, know and understand what alternatives to reporting resources exist in your community. So for example, providers working with Native communities should know about Indian Country Echo. For all providers, you can ask yourself, can you alleviate the need for a report by ensuring a patient is connected with mental health supports or substance use resources? And where do those exist in your community? Can you prevent possible harm by making sure that your patients know where they can access things like safe housing, free or low-cost groceries, and other wraparound services? And asking, are your hospital social workers and other care providers trained on alternatives to reporting? We can't just tell people to stop reporting. We have to help them help the families that they're worried about. So now I want to talk a little bit about state and tribal laws, but before I do, I want to say that tribes are their own autonomous governments, so they can and do have different policies than states. So first, I think that all governments should repeal overbroad drug testing policies and consider decriminalizing drug use. We've heard the science. Most patients can be supported with a simple verbal screen rather than a drug test. Second, prioritizing policies that put family togetherness first. That likely means not taking CAPTA money because CAPTA money requires mandatory reporting as a condition of funding. States can also fund alternatives to reporting, such as substance use treatment, getting families into safe housing, guaranteed basic income programs, and providing extra support for families with children with disabilities. And speaking of reporting, I also want to mention how important it is to educate individuals that are providing home-based family support services on alternatives to reporting. Though the stated goal is to have these specialists provide in-home positive interventions to families that the state has identified as struggling, providers have shared with me that these individuals can tend to overreport. That has to stop. The state shouldn't be sending people into a family's home and telling that family that that person is there for support, and then also relying on that same person to report the family to CPS. And family support specialists who are aware of the harms of reporting shouldn't be afraid to lose their jobs or be criminally prosecuted just for doing their job well and supporting families without reporting them. Last but certainly not least, include pregnant and parenting folks who currently use or previously used substances in your policymaking. Create working groups and fund them so that the people most impacted are at the head of the table when trying to suss out how best to support them in your specific community. And this goes well beyond policymaking on substance use and parenting. Include pregnant and parenting people in conversations about how to spend mental health money, and include folks who are up to 12 months postpartum in those treatment plans. And for folks who think, oh no, there aren't resources here, there are. There's opioid settlement money now. There's mental health grants from the administration, Medicaid administrative funding to educate. And the politics of a state aren't always protective. We see high levels of family separation, even in states that otherwise have policies supporting pregnant people. The syndemic is really complex and it requires an individual response. Every state, every community, every tribe might need something different, and people from within those communities should be planning this response. So please fund them to do that. Now I want to talk about federal laws as my last slide. These solutions are long-term, but I believe they're possible. I believe that demonstrating that mandatory reporting is actually a dire threat to public health will serve to end this policy, which, by the way, was instituted with zero evidence that it actually helped families, but that is an entirely different presentation. Suffice it to say that mandatory reporting is not an evidence-based practice. So first, we need to repeal CAPTA CARA. These laws have in part resulted in an uptick of child welfare systems involvement, which is overall a harm to families. This is not to demonize CPS or individual child welfare workers who are all working within a broken system. Rather, this is my plea for something different, something which many current and former CPS workers who often lack the resources that they need to support families are also clear is needed. Something that parents who lost their children or themselves to this system should help us create. Second, we need policies that prioritize family togetherness, routing the bulk of CAPTA money toward foster parents and not toward supporting and strengthening families falls woefully short of what families actually need. Laws that allow for swift termination of parental rights don't allow for the nuance that's necessary to treat child abuse and substance use as the public health issues that they are. And we need resources to go to program evaluation because unlike the laws that first instituted mandatory reporting, we need to do what actually works. Lastly, we need people who currently use or previously used drugs to be a part of creating housing policies. Federal laws that require termination of HUD assistance when one person in a home tests positive for substances just leave more people homeless when what they need is support. This is especially brutal for people who live in community with one another, either by the necessity of low incomes or because they live in a multi-generational household. These policies are culturally incompetent and they're harmful. And I do believe we're already funding supportive resources, but I want us to be more conscious of making sure that part of those resources go to people who use substances. We are all responsible for one another. When one individual's health suffers, all of us suffer for it, as this syndemic proves. I am so grateful that the agencies hosting this webinar today understand that the rise in congenital syphilis is indicative of deeper problems that go beyond what's on the surface. And I'm thankful for the time to bring the wisdom of so many people who are not here today in this virtual room. I want the healthcare providers and county health officials on the call to know about these two resources that I'll share briefly, and then I will shut up. So in addition to our technical assistance provision, our Repro Legal Helpline is a free confidential service for people with questions about abortion, pregnancy loss, and birth. And we do take calls from people who are using substances during pregnancy who have legal questions. And our Repro Legal Defense Fund helps fund bail and other strong defenses for people who are criminalized for their pregnancy outcomes. I am really glad that these resources exist, but I hope that we can work together to build a world where they aren't needed. Thank you all for being here, and we'll move into questions now.
Thank you, Lauren and Melanie and Caitlin and Andre and Mishka. Such incredible presentations, thoughtful presentations. We really appreciate your passion and sharing your wealth of information with us today. We have time for a few questions. If we could just sort of take down the slide all together. And the first question actually is referenced in, I believe, Dr. Taylor's presentation. That goes, what experience do you have with the use of medication-assisted treatment, contingency management, or incentives to address substance use and congenital syphilis? And this is open to Dr. Taylor and others.
Yeah, so I'll mention that briefly, and then I would love to hear the experience of others. In the Indian Health Service, the assisted treatment, multi-assisted treatment, and the use of incentives for diabetes care, tuberculosis care have been used in the form of gift cards. And those gift cards, as I mentioned briefly, have been successfully used to incentivize patients to return for care, to present for care, and to receive care when there's multiple visits that are involved. And really what we've had the most specific success with are gift cards that are for purchasing gas and those that are used for purchasing food. I don't know if others want to share. Thank you for the question.
Absolutely. Others respond? Andre, please.
Yeah, I can just add on. So contingency management has been one of our most efficacious behavioral treatments that we have to treat stimulant use disorder. We have decades worth of research with cocaine individuals that use cocaine and have cocaine use disorders as well as methamphetamine. And so what I think we need to think about when we think about contingency management and how to use it best is what is the type of reinforcer that the participant wants. And we also don't need to be afraid of giving cash as a reinforcer. That can be a powerful behavioral reinforcer. And there's data by David Festinger and others to show that you can give up to $100 in cash payment immediately upon behavioral confirmation of their response, and you don't get a return to use. So I think it's important that we don't paternalize how we're using our incentives. Thank you.
Wonderful, wonderful. Another question here, it was referenced also during the presentations, has to do with post-delivery. What is the plan of care and treatment regimen for mothers and newborns exposed to syphilis and substances after delivery?
I can speak to a little bit
Please.
of an example of clinical care. So in the postpartum period, which a lot of us will define as a year after the end of a pregnancy, mental health conditions, in particular overdose, have become the leading cause of death. And so as an OBGYN, I was trained really well in hypertensive diseases like preeclampsia, postpartum hemorrhage, things like that, but I did not receive great training in mental health conditions. And so what we need to do is change the paradigm, not just of postpartum care, which historically is typically only included a one visit about 6 weeks postpartum, to more of an ongoing relationship with a patient after the end of pregnancy. But we also need to look into how can we reshape postpartum care to also include mental health conditions alongside all the physical health conditions that we're so good already at taking care of in the postpartum period. I would also say that it's also very important to incorporate equity at all stages of how we integrate changes in our healthcare systems in the postpartum period. How can we make sure that we are making our doors open to all, and also making sure that we're eradicating that fear of entering the healthcare system in the postpartum period? And a lot of the tenets of what we've talked about today with the intersection between child welfare and substance use is important, including after the end of a pregnancy.
Wonderful. Will anyone else like to respond to that? All right. Another question here. What experience do you have delivering syphilis and substance use services to people who are homeless and pregnant? Who would like to take that? Dr. Taylor?
Yeah, well, I would just like to say that I don't have a lot of specific experience about that, but other than to say that a lot of times housing is the most important. And so opportunities to provide housing even sort of supersedes the need to address substance use and syphilis. Syphilis, again, as others have mentioned and noticed, and we recognize, is really a symptom of the larger issue of unstable housing, lack of other basic tenets of healthy living, and that oftentimes pushes women into transactional sex, which of course is a transmission route for pregnancy as another STI, sexually transmitted condition. And so that is where we really need to make sure that we have, as part of our treatment, opportunities to link patients to housing. And we have seen that. I'm sorry that I don't have specific experience or recommendations on how to do that, but we do see that as a critical need. Thank you.
Great. Thank you, Dr. Taylor. Many of the presentations address the issue of stigma. And I'm curious, one of the questions in the chat is, I'm curious to hear whether the stigma towards someone testing positive for syphilis or someone who has substance use disorder is greater or about the same. So is it the substance use that's driving the stigma? Is it the stigma or some combination? Can you talk a little bit about that?
Yeah, hi, this is Andre. I'm happy to talk about that. And I think it's both. It's an and, it's not an or. I know we've had patients at the UNC Horizons program that don't want to go to the health department to get tested for any type of sexually transmitted infection because they feel like walking through that door labels them as already having a sexually transmitted infection. And so that prevents them from seeking the screening and the testing and the care that they need. And the same is also true for substance use disorder treatment. A lot of times we have programs that are labeled substance use disorder treatment, right? And that can keep people from seeking and receiving the care that they need. So the approach that we've taken at Horizons is a very integrated approach so that people receive their physical health care, their prenatal, postpartum, GYN visits, getting all of the tests that they need, as well as their substance use disorder treatment. So that no matter what they tell us and how they choose to disclose their information, it is treated with the same respect and care and sensitivity. And so I see Mishka has opened up. So go ahead. I'm going to let Mishka add on to what I was
Dr.
saying.
Turpin.
Yeah, I just wanted to add to that and just make a comment, really, like a little bit about language. Like stigma is a term, comes from stigmata, the wounds of the crucifixion of Christ. It's a mark of otherness. It can be seen as a them problem. And I really prefer the language of discrimination because that's how we relate to other people. And we can do something about discrimination. So, like, yes, people people experience intersecting, discriminations that, can be expressed as stigma. And that's certainly true, not just around that intersection of syphilis and substance use disorder. So I think really to try to flip the script from stigma, them problem, to discrimination, us problem, and think about how we can make environments welcoming and safe for the people that we serve, safe for disclosure, safe for treatment, safe from surveillance. And to that, actually, Timothy, there's a question that in the chat that Lauren indicated she wanted to answer live. If you don't,
Please.
I can read it, Lauren. Yeah, the question is, can a provider refuse OB services to a patient that refused drug testing or other recommended prenatal testing?
And Mishka, I'd love your opinion on this as well. So I think that the laws allowing providers to refuse service are pretty narrow, but hospitals in and of themselves might have different policies that it's important to be aware of. But I also think it's good to sort of flip that question around a little bit. So, would you refuse services to a patient who was using drugs? Would you refuse service to a patient who was engaging in sex work? Would you refuse services to a patient who was Black? Right? Like these sort of characteristics can just keep going, right? When saying that you'll refuse care to folks based on something that they are or are not engaging in, I think is you're going down a little bit of a worrisome path there. But Mishka, I don't know if you have more you want to add there.
Yeah, I mean, I really, because to me, that question is like from an, I don't know legal stuff, but I understand ethical stuff a little bit, right? So somewhere like the refusal of care is unethical, whether it's illegal or not, I don't know. And there are parameters for that and et cetera. But really, this relates to whether it's somebody refusing a drug test or refusing, an STI test. And that oftentimes is grounded in, medical mistrust. And I'll say that mistrust that the patient has for what we're trying to provide them is legitimate. It's grounded in their experiences of discrimination in the healthcare setting. It's compounded by, historical memory and, generational trauma. And our mistrust of the patient, which might be what's motivating us to like discharge them from practice or not care for them, is prejudicial. It's, grounded in judgment, and it's reflective of discrimination.
Well, Dr. Turpin, you have actually segued into the final question. Thank you. The issue of trust came up several times during today's webinar. And any tips that any of you have from your own experiences of how do you best establish trust with patients that have a substance use disorder?
I will speak just as an example. I think it's important to remember the difference between establishing trust and from an expectation as a provider. I think it's important for us as we walk into the room to remember that that the patient in front of us does not owe us anything. Just because I have a white coat on, I have a lot of letters after my name, right? And I have this area that you come in to see me, that doesn't mean that you owe me anything. And so I think when we think about establishing trust, I find that a lot of my trainees, they walk in and they say, well, I need to establish trust in this first patient encounter. And I think we need to change our perception to say, no, we need to work on establishing that we can be trusted, right? Maybe one day, but not necessarily expecting that of the patient in front of us. And so how do you practice that? I think the first step is practicing humility. So when we walk into a room, to humble yourself. The person in front of you is the expert on their life. And so a common phrase I will say to my patients all the time, maybe when we're talking about a medical decision that we're trying to make together, I say it's your body. If they're pregnant, I say it's your baby, it's your decision. You're the expert on your body. You're the expert on your life, not me. Now let's talk together about how we can work together to make this decision. And so saying words like that, or saying phrases, and also using your body language, and also how you set up the flow of a clinic, just as examples practically, can show your patient that you are humbled in front of them and that you respect them for their life experiences, and also for the fact that they came in to see you that day. But they don't necessarily owe you anything.
Wonderful, wonderful. And we're going to leave it there. I want to thank our speakers for their really wonderful presentations again and thoughtful discussion, as well as all of the listeners who've been with us for the last 90 minutes. This has been a great opportunity to learn a bit more about the intersection of substance use, child welfare, and syphilis. And we want to thank you again for your participation. We'll have I believe, an opportunity. No, I'm misreading that. Okay. I just want to thank everyone again for their participation. And after all, it takes all of us working together to effectively reach our common goal of reducing syphilis and congenital syphilis cases. Many asked during the event, and we expect a recording of the webinar to be available in the coming weeks. Please sign up to our email listserv to receive updates from the OIDP STI team. A sign-up link is in the chat. With that, thank you for your participation, and for all of you who work on this bill. We do this every day to support the health and well-being of our communities. Please have a great day. Thank you.